Yeah. Oh, audible also, I guess. Okay. Audible, ma'am?
Yes, ma'am, you are audible. Audible
Yeah.
and the slides are visible.
Yeah. So we'll just do probably what we can do in the next 15 to 20 minutes and then take it from there. We'll cover only the Hammersmith Neonatal Neurological examination that is required for you to present in the exam. So it's not going to be an elaborate CNS examination, which we will do, which we should be doing in the bedside for clinical settings. So you need to know a little bit about the evolution of how a neurological examination happened, because some of the items which were there earlier have been removed now and more important items have been added, even though what we use now is also a little primitive. So there are many things which we look at for upper function and the others which for lower function, as in from upper brain function and lower brain function. So early on, we used to depend a lot on angles and on tone assessment, as in only passive tone assessment. So there are some of them who did it like the Emile Tisson angle. This is Claudine Emile Tisson, then Saint Anne d'Argacis. Okay, so even the Hammersmith examination also had a lot of focus on tone assessment alone, but then they realized that these were all predominantly lower brain function, and you're going to ignore a part of the upper brain function, which is actually more important for prognostication and what you need in the future of the baby. So many of the items were removed. Now, why are we opting to do a HNNE examination as part of the CNS in when you present a case, when you want to, like in the last case that Jaswant presented, the focus is on neurology, and especially since the baby has recovered from an acute pathology, and that is an acute encephalopathy which was triggered by something. And then your focus is to present to the examiner so that they get an idea of what is the current neurologic state of the baby. For that, you need a comprehensive type of examination. So if we were to do it like an infant examination, which you did in pediatric MD or DNB, you will start with head circumference, then you will go to cranial nerves, then you will go to bulk tone power reflexes and so on. So some of them may not be relevant in a neonate, and secondly, some of them may be what to say, skipped. So either it is not there or it is there but not required. So that's why we have to find a kind of structure that is comprehensive. That means that almost all of the domains of a neurologic examination and a neonate specifically are covered. Second is you should be able to do it in a reasonably fast manner, not just in the exam, but also in the clinical setting when you're examining the baby bedside or when he comes for follow-up. So it should be over within, say, 15 minutes or so. It should not be that you need a heavy amount of training to do it. So many of the others like general movement assessment, which Pretzel did, all of them require extensive training in order to make meaningful assessments. And the fourth is that whoever does it, it should more or less correlate. So there has to be some kind of inter-observer reliability. So you have many other points as to why an HNNE is kind of preferred. Some of these points are these, okay? So that's why we at KIMS, when we present our neurologic examination, we do it with HNNE and then we add on certain points that may be relevant to a particular case. So this is useful specifically for term babies in the first 1 week to 2 weeks. So it has been validated for around at least 17 days, but the initial one was done for the first few days. That is the early neonatal period of a term baby. And then the study investigators of HNNE extended it on to preterm babies when they reach a particular gestational age. So ideally, if you're going to do optimality scores, which we'll talk about in a few minutes, then you should do it at corrected term age. That is when you have reached a postmenstrual age of 36 to 40 weeks. But there are certain standardized formats that are given for even preterms who have not reached corrected gestational age of 36 to 40 weeks. You can do it earlier, but your interpretations will be different. Okay. So that's why we do an HNNE. Now, the components, all of you might have seen the entire form. You will have actually 6 domains. And then in each of them, you have specific items. So totally, you get 34 items in the extended or the full HNNE score. There is also a shortened screener version that we actually don't need to use because the extended or the 34 item one itself is reasonably quick and you can do it with practice. So what I suggest is when you have a baby, like a term baby who's come to you for jaundice or for feeding issues, you try to practice the components, because when you do it in the exam, it should look like you have done it on a few babies at least. Otherwise, you will really get jittery on how to do a popliteal angle, how to do a leg traction and arm traction. So you get used to the components of how you, so the quickness with which you do and the finesse with which you do on these fragile babies will be different if you have been doing it. But as against somebody who's doing it for the first time or second time in the exam. So you remember some sort of specific points. You have 6 domains and you have a total of 34 items in them. You might know what the 6 domains are, I guess. One is you have tone, then you have tone patterns, then you have abnormal movements. Abnormal signs, then you have movements, then you have reflexes, and of course, you have neurobehavior and orientation. So these are the 6 things that you have to present, and you have to also examine as quickly as possible in different sequences based on how the baby is when you start the examination. So the first component, like we thought of, or we just said, is muscle tone. So before we start on the actual components of muscle tone, I think some few points were already covered. What is tone exactly? Tone is the amount of resistance that is given by a muscle to a stretch. That means in mathematical forms, it is the amount of force change or the amount of resistance change or the amount of force change that happens or the amount of resistance change that happens for a unit change in length. So a muscle resistance will change for a unit change in length. So suppose you have a short muscle, that is a short biceps that I'm showing you here. This is the shortest point of the biceps in full flexion of the elbow. And then when somebody is stretching, then the resistance that is in the muscle for that unit change in length of the muscle. Okay, so the tendon and the muscle moves a particular length when I'm trying to extend it or somebody is extending it for me, and the amount of resistance that the muscle gives to that particular movement or for that particular change in length of the muscle is what is muscle tone. So it's not that muscle tone is one single component. There are various things that determine a muscle tone. So essentially, or very easily, you can divide it into passive tone and active tone. This is not the only classification. It's very, very different from this. But just so you understand the HNNE components of muscle tone and tone patterns, you need to understand what is passive tone and what is active tone. So when a muscle is in a very, very relaxed state, actually, when full relaxed state will be only when you have given muscle relaxants to the baby or to the person, which you will not do, of course. If it's in fully relaxed state, then the passive tone is the one which is present only because of the viscoelastic properties of the muscle. So the sarcomeric units, how much of resistance is there in between two sarcomeric units or between the actin and myosin chains, and whether they have undergone any contracture, how long the muscle was, and like suppose you're a yoga person and you have already stretched it to some particular limit, then your passive tone itself will be less. You will be able to stretch it easily without any change in resistance. So the viscoelastic properties of the muscle, which is determined by several other factors, is the one which affects passive tone. But never is a baby in completely relaxed state, because there will be some intrinsic muscle neurologic activity that is happening in the muscle, which is actually detectable even by EMG if you do a very good quality EMG. So passive tone is a combination of viscoelastic properties with a baseline underlying small amount of muscle neurologic activity that is happening. But active tone is when there is active firing of neuromuscular units happening into the muscle. That may be voluntary, that may be involuntary also, but it is more controlled by certain active neuromuscular units firing. So this will definitely be able to be picked up by an EMG. So whenever a baby is doing something voluntarily or in response to something that you are doing, not just on the viscoelastic property of the muscle, then that has got a higher relevance than passive tone. So the active tone that is deliberately shown by a baby to your movement should be higher ranked or higher scored than the passive tone. Makes sense? Because if the muscle is in contracture or your inhibitory inhibitory controls from the central nervous system are not there, then the passive tone will be very high, which is not good. You don't want a very high passive tone. You want a reasonably good, okay passive tone, but along with that, you want a good active tone. So active tone is what the baby is actually doing in retaliation to what you have done. Okay, it's not just about the amount of resistance that is felt in the muscle to a particular stretch. I hope I'm making some sense to you. So basically, if you want to pull back, then that is active tone. But if I'm just not able to stretch because the muscle is all not stretchable, our inhibitory controls are not there and a lot of active controls are there, facilitatory controls are there from upper end, then the passive tone will be good, or it will, you can't say use the word good, passive tone will be high, but the active tone will not be good. So for that, that's exactly why I said you need to know some basic controls of how the muscle is controlled. So you have the CNS control, that is, it comes from the brain. So the brain itself is not just the brain, it will be the cortex, it will be the prefrontal cortex. You will have the whole of the basal ganglia, specifically the thalamus that you're interested in, also the caudate putamen and the globus pallidus. You have the cerebellum also, which is fine-tuning the movements or the tone. Then you have the reticulospinal tracts or the corticospinal tracts that are coming down, the various areas through which this passes, like the internal capsule, you also have certain, once you reach the spinal cord, you have the anterior horn cell, you have interior interneurons happening, and finally it is a muscle spindle, right? So finally what gives you the answer is what the muscle spindle is doing to whatever you have done to the baby. But the controls come way above that. So for that, you need to know that there are some inhibitory pathways, as in these things will prevent passive tone from increasing too much. Okay, so if those pathways are cut off, then passive tone becomes high, abnormally high, which is not desirable. Like suppose you have the medial reticulospinal pathways that are coming down from the prefrontal cortex. This is a inhibitory pathway. So if this is cut off, that is the prefrontal cortex's control is gone because he's asphyxiated, he has become a severe infarct is happening there, or if the baby doesn't have, has a large porencephalix cyst sitting there, or he has a CNS malformation which doesn't allow his cortex and prefrontal cortex to give in that inhibitory controls to the muscle, then that muscle is going to exhibit a passive tone which is very, very high, which is not desirable. You want the inhibitory controls to also come in order to prevent an excessive passive tone from coming. Okay, so the highest amount of degree of freedom, that is the ability to take decisions and the ability to control, is highest in the cortex, all up there. Then your fine tuning happens in the basal ganglia and the thalamus and the cerebellum. These are structures which don't have so much of degree of freedom. They act based on the signals that are coming from the top, but they learn based on those signals. Okay, so if the baby has been always having a low inhibitory control coming from the cortex, the basal ganglia and the thalamus also learns that, okay, this is probably what this baby is supposed to be happening, and becomes a tight baby. Similarly, if you have a lot of facilitatory controls coming because the inhibitory pathways are all gone, then also the baby becomes tight. So it's like, I'll give you a simple example. Suppose you have a company where you have a CEO. The CEO is the person who is highly qualified also, it's a hypothetical situation. At the same time, he has the ability to control everything, and he also has the degree of freedom to control. So it's not enough if you have a junior staff sitting there who has the same qualification as the CEO, he has the same abilities as a CEO, but he doesn't have the freedom to take decisions for what is happening down there. Okay, so you have to have the highest degrees like the CNS. So the prefrontal cortex and the cortex will actually teach what is, or at least train the lower people what to do, because something is pathologically gone wrong with the brain, or because they're normal. So if you have a normal frontal cortex and a prefrontal cortex, then he will train the basal ganglia also. But if the basal ganglia is abnormal in itself, like the junior employee itself is not in a position to take decisions, they don't know what to do, then that itself can cause a problem lower down. So that will show you where the lesion has also happened. So like, for example, just a simple observation, just when the case that you presented, that baby looked very, very abnormally adducted and a little too hypotonic, right? So, but very bright in the face. So I'm wondering if we probably are missing something which is a lower control problem. Like you have, if you have a central hypotonia, usually that fellow should not be so bright looking. He should not be able to directly feed, or you might have multiple seizures happening. You might have brisk reflexes. But if you have a baby who has a problem lower down, like in one of the spinal pathways or the reticulocortical spinal tracts, or if you have a neuromuscular disorder or a neuromuscular junction disorder or a myopathy, then the baby will look bright, but the baby will look hypotonic. And he may not have seizures. He may not have reflexes that are easily elicitable. His proximal muscle tone will be low. His power also may be low, because this baby's anti-gravity movements also looked not so great. The spontaneous movements were also not so much, but he was looking very, very bright. So I'm wondering if the asphyxia was because of something that was wrong neuromuscular underlying. These babies also don't cry at birth, so they require resuscitation, and they invariably go through the therapeutic hypothermia circle. So that baby might be an underlying Prader-Willi syndrome, or it might be a proximal myopathy, which might get picked up later, or it might be a milder form of an SMA. So your tone is controlled by various pathways. I think I'm deviating too much in the short time, but you needed to understand the basic rules of muscle tone, that you have various levels, and these levels have different degrees of freedom. And finally, what executes the tone is the muscle spindle, but the muscle spindle has the least amount of control. So it is the lowest employee which actually goes and does something, but he doesn't have the freedom to make a decision. He does whatever is given from above, whatever order is given from above. And his own ability to do that also depends on how he has been trained. So if the muscle spindle has been trained always to be tight, then he will remain tight, even if the primary problem has actually become passive. Okay, so that is a basic rule of muscle tone. Important, passive tone should never overtake active tone, because passive tone is actually a more inferior form than active tone. Okay, so that's a basic principle of the second component of HNNE, that is the tone patterns. The second, one more important component that you need to understand before you go into HNNE is that you have a specific order or a specific sequence in which the tone progresses ontogenically. So in a fetus, it always increases from caudal to cephalic, which means that the lower limb tones is better, flexor tone of the lower limbs is better, then it goes up, and then finally the upper limb tone also becomes good. Then the up cephalic, that is the flexor extensors of the neck, also become good. So you have an order in which the tone increases. Along the same order, the tone decreases as the baby becomes older. And then the active control happens cephalocaudally. That is why you get head control first, then you sit, then you stand. You don't do the reverse. If you're doing the reverse, that means something is wrong. As in a baby who's already extensor and able to stand up when you pull to sit, but doesn't have any head control, means that it's not that he's standing much earlier than he's supposed to stand, but he's actually got a wrong order ontogenically, and there's something wrong. Some pathology is there. So the progression of tone is from caudal to cephalic. The release of tone is also from caudal to cephalic, but active control happens cephalocaudal, right? So that's the second thing. Third thing is there are certain groups of muscles that are expected to have lower tone than the opposite group of muscles. Like, for example, your extensors of the back. So whatever yogi you are, how much of yoga you do, you will always be able to flex better than your ability to extend backwards. I'm talking about your spine. So if you're a solid yoga person or a dancer, then you might be able to go all the way back and extend yourself, because not because your extensors are very strong, but because the flexor tone is not too tight. So that's an abnormal situation. You'll always be able to bend forward better than you'll be able to go backwards. Okay, so that's because your extensor tone is always lesser than your flexor tone. That is another rule. All right. So your extensor tone should be lesser than your flexor tone. That's why you will be able to bend forwards better than go backwards, because the resistance of the extensor should be not so much. Okay. Tone high means the resistance is high. So if you're able to flex, it means the extensors are not tight. Okay. So that you should never have an extensor tone that is better than a flexor tone. All right. Okay. Done. Now, each component we will go to. This is the first segment, that is tone. Okay, tone has got multiple components, half of which I have cut and put in this slide. Now, the good thing about HNNE, one more, is that you have specific instructions given as to how to do the test. So we'll see it in the video, so I won't go. In this, the first part that you will see is just like what we said. We will see the order in which the tone has progressed from caudal to cephalic. So the amount of importance that is given to the lower limb tone is much higher than the amount of importance you give to the upper limb tone. So tone, posture, you usually observe when the baby is lying quiet before you even touch the baby. And it's the predominant tone that you are bothered about. He may move about a bit, he may extend, he may flex, all that you do. Calm baby when he's lying there, whenever, whichever point he's calm. It need not be in the beginning of the examination. It can be anywhere through the examination. Before you touch the baby, if you want to observe the posture of the baby, he should actually lie in such a position that your leg flexors are looking better than the upper limb flexors. Both can be flexed. In a term baby, both can be flexed, but the reverse usually should not happen. As in, your upper limbs will be very flexed, but your legs are high extended. This last one doesn't look normal, because you know that your flexor tones of the lower limbs should actually be much stronger than the flexor tone of the upper limbs by ontogenic caudocephalic progression. Okay, so it's these three that will look kind of normal to you because they fit into your criteria. If these two will be what you will expect in a term baby. Preterm baby might have slightly like this. So if you have confusion as to which one to put that baby, you put what is predominantly the lower limb tone. That has more importance than what is in the upper limb tone. If you have different positions that the baby is assuming. Arm recoil and leg recoil. These are essentially what you do for passive tone. That is, you just stretch quickly and then you release. You see how much that the muscle has resistance, it will just pull back. It's not like a voluntary action done by the baby. It just pulls back immediately because of certain viscoelastic property in the muscle. So recoils are usually more of passive tone. Although this kind of classification is not, you won't find it in a textbook. It's just for you to understand. So you're doing a quick movement and you're releasing so that it goes back to its original form or to where it is supposed to be. And then you see what is the response. So there are two parts to the response that you see in recoil. One is you see how quick it is, that is how fast it is. Second is you see the degree to which it comes back. So it's two things. Okay, so one is it should be fast, and the second is that it should be full. That is, you see the extent to which it is coming back as well. It may be fast, but it may stop halfway through. It may be slow, but it may come fully. Okay, so you have to actually see what happens in the first few seconds of doing it. And we usually do arm recoil and leg recoil together. That's what the HNNE does. They have standardized the method that way. Therefore, we do both sides together. Okay. It's not wrong that you do one side and then the other side. Maybe the baby has a cannula on one side. You may not be able to do on one side. Then you have to comment on it like that. But the method, standardized method that HNNE people, that is Lily Dubowitz and Victor Dubowitz, they did it this way. That is how they standardized it, that they do it both together. So when you're reporting in the exam, you have to tell them that we did it together. Okay, I did the examination of both sides simultaneously. All right. So next is what? Leg traction and arm traction. Now, these are two tests that give you some kind of indication of how good the active tone of the baby is. Okay, because you're doing a slow movement, which we will see. You're pulling up either the wrist of the baby and you're looking at how much resistance is there at the elbow when the shoulder is trying to lift off. You can feel the resistance also, and you'll be able to see the angle also when you're lifting off the arm. Similarly, I am not able to lift my foot all the way up here, so I can't show you how to do leg traction now. We'll do it in the video. So when we pull the ankle, that is, you hold at the ankle and you pull the baby's leg slowly upwards against gravity in supine position, then you see the resistance that you feel when the buttock is almost going to lift up. So you see both things. You feel the resistance and you also see the angle that is formed at the knee. At the knee when a leg traction is done. Similarly, for arm traction, it is the angle that is formed here when the shoulder is going to lift off. Okay. Then the next component. The next component is popliteal angle, which is one of the most favorite questions. Demonstrate popliteal angle is almost invariably going to be asked to at least 50% of you. So we will see it in the video. There's a technique to do it. Actually, Amil Tison had a different technique, but HNNE's Lily and Victor have a different technique. So you can do it each leg separately. So test each side separately is written there. Okay, very clearly it's written there. And we have to negate the component of the hip there. So we're already flexing the hip on the side of the abdomen. They say onto the abdomen, but that may not be very comfortable to the baby. So you flex the knee on the side of the abdomen, and then you extend the knee with one index finger, and you see the angle that is formed between the calf and the back posterior part of the thigh. Okay. The calf and the posterior part of the thigh. You're not looking at heel to ear. Heel to ear is the angle between the bed and the heel. Okay, this is the angle between the thigh and the posterior part of the leg. That is your calf muscles. Okay. Next, head control 1 and 2. That is flexor and extensor. So what did we know? We know that flexor tone of the head should be better. Which means what? If your baby is in full extension, he should be able to lift better than his ability to lift up. He may be able to do both, but we don't want him to have a better ability to lift up rather than bring forward. Got it? Which means that your extensor tone should not be better than your flexor tone by large degree. It may be a small difference. We'll see that in tone pattern, but you don't want the head to be predominantly like that. That is probably a sign of excess hypertone. Okay. So your both may be low, both may be good, but you do not want the extensor to be very much higher than the flexor. That is an abnormal finding. The next is head lag, which also helps you to compare these two things, that is head lag and ventral suspension. So in independence, each of these components have their significance. Combined together in tone patterns also, these have significance. So when you do head lag, this method, personally, I do not prefer, because there is another school of thought that if you pull the infant from the here, okay, if you pull at the elbow like that, there is something called a shoulder stretch reflex, which will get activated and the baby's head will go like that. So I prefer to keep my baby like that around the shoulders and around the chest and lift. It also looks very aesthetically better to the baby. It looks more comfortable rather than pulling the baby like that. Okay, so you are able to control, even with one finger, you're able to hold the back of the head. Because what are you testing? You're only going to test if there is a head lag or not. You don't have to demonstrate that the head is going all the way back and make the baby going for obstructive apnea or severe respiratory distress. Okay, so you don't want that. So you want some control over what you're doing. So you can encircle the whole shoulder of the baby with your two hands, and then you can keep one finger behind the baby's head and then lift. That also is there in the video for you. You only need to feel if there's a bad head lag or not. Okay, that you'll be able to find out even if you do it by this method. But HNNE says pull. So if the examiner says, why you're not doing pulling, then you do pulling over here. But if you're doing it with some degree of freedom and the examiner is not commenting negatively on your method, then you do it this way. Okay. Same in clinical practice, I'd always recommend this way rather than pulling the baby as recommended in this format. Ventral suspension. This is again one more thing that you need to be a little careful. You do not want the baby to vomit. Okay. So make sure that you keep your baby on the chest on your hand, not on the abdomen. So you don't want the abdomen to get compressed. You want the chest to be on the palm of your hand. Do it very gently. Put him in ventral suspension only if the baby is okay to do. If there are several components of the HNNE, which if you don't do is perfectly all right, depending upon what the status of the baby is. If the baby is on ventilator, obviously you do not want to do ventral suspension. You do not want to do head lag. You might displace the tube. Leave all that. Do only whatever you can do. You could do popliteal angle, you could do leg traction, arm recoil, arm traction, all that you can do. Posture you can look at. You can look at neurobehavior. You can look at abnormal signs, but you need not do ventral suspension and head lag in those babies. Flexor tone, extensor tone of neck, not required. If the baby is a fragile baby who's on ventilator or any kind of intensive respiratory support. Okay, so keep the baby chest there. And then there are three things that you look at. You will look at the trunk, you will look at the lower limbs as well as the neck. Now, this is important because the neck and the trunk tone, this is axial tone. That is your central tone rather than appendicular tone. Appendicular is upper limbs and lower limbs. Axial tone has a better upper brain relevance than appendicular tone. Okay. So if your upper brain is in reasonably good health state, your axial tone should be reasonably good. It's not enough if you have good appendicular tone, but very bad flexor extensor tone of the neck and of the back, that is of your spine. Then it means that your axial tone is not as good as your appendicular tone, and your upper brain may be not as good as you think it is. Okay. So these are some variations which have happened over several years, that many of the primitive reflexes have gone, many of the passive tone reflexes have gone, passive tone examinations have gone, and that axial tone has been given some more relevance than appendicular tone. Okay. But that said, in exam, you have to do most of whatever components you're able to do for that baby in that situation. So we've covered most of the first domain, that is tone. Shweta ma'am, is it okay? I'm feeling bad for the candidates.
Uh, as such, from 82, we have just now 76 students still attending this session. And I think next, how much time you require, ma'am?
Ma'am, I'll run through it then. It's okay. I can cut it short. What do you
Let's
think?
take an opinion. What is the opinion for the students? Can a few of you write on the chat box? Okay, great. Excellent. Students are still, as such, ma'am, your teaching way is such a interesting. No, even I am also not feeling bored. So you can continue, ma'am. Such a from basic to you are taking it, no? It's really very, very appreciable. So please continue, ma'am.
Okay,
See, the
ma'am.
students are writing. Please continue.
Okay, ma'am. Then I'll do that. Okay.
So
Whatever
please
best
do
can.
it in the detail. Whatever you are doing, don't cut short. Students are
Oh,
writing.
sorry, ma'am. Sorry
And
about that.
that's really a commendable thing, ma'am. Your teaching is amazing.
I'm not seeing the chat box. I'm just going on. Okay,
No,
ma'am.
I'm looking at the chat box, so you just go on.
Okay, ma'am. So yeah, so we saw posture, we saw each component of tone. Now we will go to tone patterns, which we have actually finished. Just recall three things we told. One is that we do not want upper limb tone to be lower than lower limb. Upper limb tone to be better than lower limb tone, because that is not the ontogeny of progression of tone. So we do not want a baby who is highly flexed at the upper limbs but highly extended at the lower limbs. That's not desirable. You want the flexor tone of the lower limbs to be better than the flexor tone of the upper limbs or equal. Okay. So you look at the first component, you see that, where are we? Okay.
Upper limb and lower limb tone.
Yeah. Posture in supine. Yeah. That if you look,
Yes.
arms and legs flexed is okay. Strong arm flexion with strong legs extension is not good. Okay. So these two are not good. They've left the first two because if you find something different, you can actually jot it down there. Okay. So that's what you do for the first rule. Second rule is what? You do not want the passive tone to be much higher than the active tone. It's okay to be equal. It's okay to be one column better than the active tone maybe, because there's a lot of ambiguity in how you assess those things. So you don't want the passive tone components to be 2 columns to the right. That is more progressive or more higher than the active tone component. So what are the passive tone things we did? One we did was popliteal angle. We did, okay. And what you can compare it with? You can compare it with leg traction. So you can take popliteal angle roughly as passive tone, and you can take leg traction roughly as active tone. So you want leg traction to be somewhat equal to at least or better than popliteal angle. Okay, the score that you get. So if you go backwards, you will see here. So if you see leg traction, if you grasp and if you get this kind of leg traction, okay, but at the same time in popliteal angle, if you see, if you get this, it's a very tight popliteal angle, but you don't have as good a leg traction, which was this. Then that may not be so great because there's more than 1 column difference between this fellow and this fellow. Okay. At the same time, if you find, say, a leg traction which was here, okay, and your popliteal angle which was sitting here, it's okay. So you do not want a popliteal angle to be more than 1 column to the right of a leg traction. Okay, so that's done. The third rule was what? Head control. You don't want extensor tone to be higher than flexor tone. So there are 2 ways of assessing this. One is you look at the upright position and see whether he's able to lift like that versus lift like this. So his ability to lift like this should be equal to or better than his ability to go backwards. Okay, so if his head is back to start with and if he's able to bring it up in the first 30 seconds of your examination, that's a reasonably good flexor tone of the neck. But at the same time, if he's completely like this and he's not able to come front, okay, either it means that he's highly floppy baby, or it means that your extensor neck tone is much higher than your flexor neck tone, correct? Which is not desirable. Okay, so if your head control flexor is this, but your head control extensor is very, very high here, not good. Okay, the reverse is all right. Reverse is actually okay. Same thing if you were to look at these. Okay, take some time to understand this head lag. Head lag can lag either because of severe hypotonia when you're pulling the baby up, or it can be because of severe hypertonia of the extensors of the neck. Right? Now, how do you differentiate that? You put the baby in ventral suspension. And if in ventral suspension, the baby is like a rag doll, like this, like a U shape, he's completely floppy on himself, then it is generalized hypotonia. But if the baby is like this, holding the baby like that, and your baby is arched all the way like this, then it is extensor hypertonia. So your head lag score and your and your ventral suspension score, if you were to compare, your ventral suspension should not look like this versus a head lag of like this, which will mean that there's actually extensor hypertonia, which is not good. Okay, so we saw 2 or 3 rules in the tone patterns. So more than 1 column difference where passive is better than active, extensor is more than flexor, and upper limb is less than lower limb. Sorry, upper limb is higher than lower limb flexor. These are not good. Okay, go through it once more. You will understand when you go through the rules of the tone patterns. So that's exactly what we did.
We will share the recording so they can go again and again. It requires them to go through repeatedly and do on the baby.
Yeah. So tone pattern
Yes.
doesn't require you to do an examination again on the baby. It is based on the previous page. So whatever scoring you have done on the first page of posture and tone, the same things you compare in the tone patterns domain, and you're able to get the interpretation. So this page, which I have displayed now, doesn't require an extra examination of the baby. It's already done. You have to only compare the scores between each thing in the first page. Okay. The third one is reflexes. Initially, actually, Hammersmith, Hammersmith is the name of the place, the hospital where this was designed, by the way. And these 2 people, Lily and Victor Dubowitz, I'm not sure if they're husband, wife, or siblings, not sure, probably husband, wife, who wanted to take away DTR, that is deep tendon reflexes, because they really didn't have much relevance in a non-floppy baby. Okay, so you take my point. If it's a term baby who is in asphyxiated and getting recovered, or if it's a preterm baby who has reached term gestational age, the DTRs may not have much relevance. But when they removed this, they found that residents were not doing it. So in order to continue the the ability to do the test. You will forget how to do DTR if you don't do it. So in order to keep that skill going, because it's relevant in certain cases, they brought it back in. Okay, so the DTRs have brought back in, and except for triceps jerk, if you look at it, you look at biceps, knee, and ankle, right? Those are the three, because the triceps are essentially not easily elicitable in a newborn, because the triceps are an extensor group of muscles and they're not great in a newborn. So extensor, you don't have to do tricep jerk. You have to do only biceps, knee, and ankle jerk. These are the ones which you can actually elicit in a neonate. Where does this become relevant? It becomes relevant in a floppy infant. Like we were thinking about Jaswant's baby, probably this will have relevance there to see if it's a subtle SMA or a neuromuscular junction or a myopathy. You might be able to find a decreased DTR or an absent DTR. If it's a central hypotonia, it may be an exaggerated DTR. If you've got a DTR, you can actually rule out SMA. So it is important to do DTR in some babies in the HNNE as well. Okay. So ideally, a gentle knee hammer has to be used, but you can use your finger in a preterm baby. Don't use a step. It looks very unprofessional. Okay. Now, even though I do it. Now, next one is suck and gag. That has some relevance because this has some practical useful. Like that if they can suck and gag, they can feed. So it's relevant to you in day-to-day practice. You can put them to the breast, you can offer pallida feeding, you can give them bottle feeding if you have a suck and gag. So it is a little higher mental, really not. Even anencephalic babies are able to suck, but it has got relevance in your day-to-day practice. Therefore, you do. This is an elicited reflex. You're actually supposed to put your gloved finger into the palate and touch. So if you touch and if you're getting stripping movements, that's good. If you are having to stimulate the palate a little bit in order to get the stripping movements, then it is a little lower ability of the baby to suck. Gag is actually not tested if the baby can suck. You can leave him alone. Okay, if the baby is not sucking or it's just biting, then probably you're dealing with some pseudobulbar or bulbar palsy. Then you might have to check by just deepening your finger a little bit. You don't have to make him go and choke and gag and all that. He doesn't have to be cough. You can actually elicit if he's going to start gagging. So stop there. Okay. So these habits will come when you're starting to do an exam repeatedly on a baby. Now, these two also, I'd rather say that the plantar and palmar grasps have relevance if they're asymmetric. Okay, so if you're dealing with a baby who's had a stroke or who's evolving periventricular hemorrhagic infarct, then you might find an asymmetry in the palmar and plantar grasp that has got more relevance than a completely absent palmar or plantar grasp. So you might find a very sick baby who's not able to grasp. That doesn't mean anything. But if you have a baby who can grasp on one hand but can't grasp on the other hand, that means something more. So if you see the last two things, these two, if you have noticed in a Hammersmith examination, that is meant for state and for asymmetry. So you can actually write there if it's asymmetric, right more than left, right more than. And you see, there's one more point. No, can you see these also? So you can get different responses. You saw, no, in yellow, different responses on right and left. So it doesn't have to be the same, right? So you can record one circle for the right upper limb and one circle for the left upper limb with a different color. You write there. The left can be circled and I say, in the left I got this, but in the right I got this. Okay, so that also can be mentioned in your asymmetry column. The state you mentioned, because if the baby is in extensively crying, you might get an abnormal posture, it might not be relevant then you tell them that, okay, I saw it in state 4, state 5, but I need to re-examine it. So you might want to write that here. You may not have been able to examine it in the ideal state that you should examine that particular item. Okay, so again, gone back. Now, this personally, I don't do the placing reflex because it's highly disturbing to the baby. But if your examiner suggests that you do it, you should know how to do it. You can't do it at the edge of the bassinet because the baby can't lift his leg all over on the side support. You have to remove one part or you have to move to some other place where you have only one edge where the baby can place the foot on top. So that's difficult in the bedside. That's why I've stopped doing the placing reflex personally, but you should know that there's such a component. Morose reflex also, you don't have to do it dramatically. Okay. And that to the method that Hammersmith does is that you're supposed to hold the baby completely in your arm and then drop him like that. We do it on the bed, right? Most of the time. They do it here on their own arm. They hold the baby in one arm and they hold the neck in the other arm and they extend and they see if all the components are coming. Abduction, extension, flexion, and adduction with opening of hands and crying and all that. So again, here, asymmetry will be more relevant than absence or incompleteness of the Morose reflex. Okay. Movements, I think partly Dr. Tapas had mentioned that you're looking at quantity and quality of movements. These are two separate items now, if you see. Spontaneous movement quality, spontaneous movement quantity. Quantity will be how many spontaneous movements you it's not stimulated. So it's something that you have to watch before you disturb the baby, and you see how many movements are coming. There's no real number. It's called frequent or infrequent, but you get a general idea when you have seen number of normal babies, right? So you compare with that in your head. And quality is based on several relevant things. It is based on how latent the movement is, how habituation happens, and how much of diversity is there in the movement, or how different they are. Okay, it's not just about the number of movements, it's about the quality of movement. So if you get fluent alternating movements of arms and legs with good variability, that sounds like a good thing, but you may not get as frequent fluent movements in a preterm baby. So the number of babies may be small, number frequent or infrequent, but the quality which you see might be good. It need not be stereotypical same type of movements which are happening, or jerky movements that are happening. In a newborn baby, you're supposed to have a dance like movement. It is supposed to be fluent, and it should start with one hand, then move to the other, or it should involve all together. And you have different types. The ranges may be this way, it might be this way. So if you're getting the same type, then it becomes like an automatism and all that. Okay, so it should be diverse. It should start with some latency, and if you're doing it with stimulus, it should get habituated. But here you're looking at only spontaneous movements. In this component of HNNE, you're looking at spontaneous movements. You're not looking at stimulus-induced movements. That will come in your irritability and in your consolability. That's different. Okay. Head raising in prone is one more that we usually don't do because it causes some distress to the baby. You have to put the baby in prone position, put him in such a way that his nose is like that, and see whether he's able to lift and move his chin on either side. The babies will do, term babies will do, especially second day, third day, they will do. If they're jaundice babies whom you have readmitted for phototherapy, you can try, you can put them, they will get up, they will look that side, this side. So it's not that they have good tone of their neck muscles. Even the term corrected age preterm babies who are doing really well medically, if they don't have any illnesses like BPD and all, they should be able to do this and this. So this also comes in movements component. Okay. So I think we've covered tone patterns, then we've seen reflexes, and we've seen movements. Now we have two more to go. One is abnormal signs. Over the years, people have seen that there are certain signs of the hands and legs which are not looking good, which means there's something wrong with their CNS. One is if they're always approximating the index finger and the like showing a super sign. Okay, so this is not good. Always keeping like this is not good. This of course is not good. You know that. The second is if the toes are always clawed like that, it's not good. Or if the big toe is always fanned up. Okay, this is my footer. If it's always fanned upwards like that, those are also not good. So clawed up, this and this. These things are not great. And then you look at tremor and startle. So these also, it can happen over the course. You might create some noise, no, when you're doing, or something will happen when you're examining. That startle is enough. You don't have to hit the bed and create another startle. He may startle to something else, or he may not startle to something else. And then you look at how he comes back from the startle as well, and how the tremor is during the course of your examination. Orientation and behavior is little important because these are, of all the different things, one of the things which give you something about the upper brain function, even with a caveat. There also you have to take it with a huge pinch of salt, because even multicystic encephalomalacia babies may be able to fix and track, which means that itself is not a clear-cut sign that his upper brain is okay. But if a baby is able to fix and follow, and the rest of everything is normal, and his neuroimaging is normal, then it gives you a good negative predictive value that this baby may be okay. So it can't be taken in isolation. You can't say that just because he's able to fix and follow, his occipital cortex is good and his visual processing pathways are good. You can't say, because even if the baby has hardly any real brain tissue there, also they will do. The subcortically also they will do. So, but these are tests that have to be done, especially in the exam, and there has to be some standard method of reporting it. So therefore you do it. So this also we'll see in a video which I actually showed you last time. The last three, that is alertness, irritability, consolability, are done as a response to stimuli. Okay, so whatever stimulus, you don't have to do a new stimulus. Like for example, you've done a visual orientation stimulus with a ball, a red ball or a target. You see two things here, no? You see a B and a T. So the target is like a bullseye. You have a black and a white, like you throw an arrow. A ball is a red ball, which they found that babies tend to look at more easily. So you do both and you take the better response. Okay. If you don't have, you do at least with the red ball. Okay. And you take the better response, the best response that you get. And what is your alertness to that target? So you look here, tested as response to visual stimulus, either ball or target. That is how you say alertness. It's not how primarily alert that fellow was. If you've done the visual orientation test, what was his response to it? That has to be scored in the alertness. Same thing with irritability, it's in response to stimulus. You have, say, opened his diaper, you have disturbed him a little bit to examine popliteal angle. Did he get very irritable? And from there, how consolable was he? Did you say, it's okay, baby, and then he became all right? Or did you have to touch him and he became all right? Did you have to carry him to become all right? That is scored in your irritability and the type of cry that the baby happens. Sorry, consolability is what we said last. So those are the 6 domains, 34 items. Okay. There is a summary which is right at the bottom at the H of the HNNE scoring form. You have your ability to write in text what you feel. Like you can write list deviant signs. You can actually write other things that might not be there in the HNNE. You have to, of course, always see the OFC. You have to look at sutures. They're all part of CNS examination. And there's one large thing which is actually missing, which is the cranial nerves. Okay. So cranial nerves I'm not discussing because it's not part of the HNNE. Optimality score you people probably need to know for the sake of exam. This is done only for research purposes. You don't have to do it on the bedside. You don't have to do it in the exam. You need to know that there is something called optimality score that the HNNE designers did. This they did by looking at 200 plus term babies who were normal otherwise, and they saw how many percentile of them were fitting into which of those 5 columns that you see in each. So you see that all of them have 5, right? Yeah. So 1, 2, 3, 4, 5. So if they found that 90% of the babies were sitting in these 3, then they scored that item. That each item has a different optimality, yeah? Then as 1. If say 5 to 10%, the remaining 90 has another 10, right? So 5 to 10% of babies were doing something, say here, then they gave it a score of 0.5. Okay. And if less than 5% of babies were doing a different thing, then they gave it a score of 0. So it's like the WHO drew the centile charts for growth, that 3 to 97 centile will fall within that particular panel or the road to health card. But doesn't mean that the fellows who are falling below and above are always abnormal. It's not like that. It just means that they are different from the rest of the babies who are generally within the 3rd and the 97th centile. So optimal, they would take as those babies who 90% of them would show. The remaining 5 to 10% will be 0.5, and the least number of babies, if they behave in one particular form, they take a 0 score. And then they add up for each item. So each item has a different optimality. Like, for example, you saw tone, maybe the middle ones are good. If you look at, say, movements, you will find that this is abnormal, this is also abnormal. Yeah, that's not a good example. If you look at abnormal signs, only the right hand ones may be bad. So it doesn't mean that optimality score means only the center is good. Not like that. For each item, the optimality score is different. Okay. So they have shaded in the optimality score in the big HNNE manual, which item is which column out of the 5 will fall in score 1, which one will fall in 0.5, and which one will score in 0. So if your baby is sitting in 0, for that item, his score is 0. For next item, the score may be 0.5, something else may be 1. So an overall score they did for research purposes, and they found that if it was less than, your total you can reach is 34, right? 34 items into 1, which is the maximum score. If they found it less than 30.5, then it might be predictive of a bad neurological outcome later on. We did our own study and we found that 32.5 was actually more in the ROC, more predictive of having abnormal neural developmental outcome at 18 months. Okay. So it differs and you're not expected to do this. There's one basic defect in this. So suppose this baby has done well in say tone, but has done very badly in visual and behavioral orientation. His total score may become high, no? And still the baby may have a bad outcome. So each of them also taken in isolation may be better than if you add the entire score. So that also you have to remember that optimality score is not ideal if you take it in whole, because the baby may make up for it in some and may fall back in the other. Then in that case, you're not going to address a potentially abnormal baby at all. Okay. So I think that's enough. Change the examination. Yeah. Now, the sequence of your examination, you're supposed to do based on how the baby is when you start with, and then you can change it, and then you can come back and report it in the correct order. The tone was this, tone patterns was this, and your behavior was this, blah, blah, blah. But the sequence in which you do it may be different based on how the babies were. Ma'am, I'll quickly just finish some videos here.
Sure.
Okay. think one or two I already showed you last time. I will show you head lag. Is it seen, ma'am?
No, I am able to see uh, yours. No,
Not.
your screen is not visible.
Uh-oh.
I think
Oh,
you have to share the screen.
I thought I was already sharing, ma'am. 1 second.
You were already sharing, but just now you have changed.
Oh, okay, ma'am. Just a minute, ma'am. Yeah, I did stop. Sorry.
Yes, now it's your screen.
Yeah. Now, ma'am?
Yes, yes.
Yeah. So this is or not in order at all. I'll just
It's
randomly.
okay.
Yeah. So this is like I was trying to attempt head lag. Madam, very good. He's already crying, baby.
No, video is not visible. Your screen is just visible.
Video is not playing,
Just
ma'am.
click it, double click on the video.
It is playing here for me, ma'am. Now?
No, it's not playing here.
Madam, very good.
We are able to hear the sound or the instructions, but not the video.
I don't know, ma'am. Then maybe I'll just cut it and start once more. 1 second, ma'am.
Okay.
Mm. Just try another one. This is what I showed last time. Is it seen, ma'am?
No.
Good. That didn't work then, ma'am.
It's not working.
Yeah.
Last
Last,
time we could see.
yes, ma'am, it did come again.
Mona Lisa is writing, ma'am, first open the video and then share.
Now?
Yes, now it's visible.
Okay, good. That's technical advice. Yeah.
Hmm.
Okay. So this was what I did for visual orientation. You're supposed to do it with the dead ball or with the target, but this fellow was actually looking at my face better. Some visual orientation was there. Yeah. Okay, so you are supposed to use a red ball or a target. Okay, not this. Observing and movements. Okay. Ma'am, that means I have to open everything and keep, right, ma'am?
Yes, every time you have to open and then share.
Okay, ma'am. Now, ma'am?
Yes, yes, yes.
Okay. Madam, very good. Okay, this is head lag, which I said you enter the
Yes,
ball with shoulder and then you.
yes, 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 yes.
Yeah, instead of pulling at the wrist, this gives you a reasonable. Now I've dropped the head a little back so that he can try to lift it. Now make sure that it is actually 90 degrees. My method is slightly wrong because he'll have to put in a greater effort if it is not 90 degrees, right? To pick it up all the way from the back to the front. Yeah, you saw that, no? So some flexor he did go. Now he's already fallen forward and he's trying to move it up. So he's showing
Yeah.
some extensor and flexor tone, which is not too different from each other. Okay. So that's how you check for head lag. Make sure the baby is in 90-degree position. This is slightly too much 45. So the amount of effort he has to take to extend may be much higher than to flex. So that part has to be taken care of. Now I'm stopping sharing again.
Mm.
Sorry for being such a boomer. 1 second. Okay. Now I will share, right? Okay. Same. This is leg recoil. So you do both together. You do extend for 3 seconds and then you leave it. Okay. So you see how good the fastness is as well as how much extent is there. Two components. Okay, so I flexed it, then I extended it, waited for around 3 seconds, and then I left it. Same thing with the arm. The IV cannula is there, so it's not going to be great. We saw that there is an asymmetry, probably because of the IV cannula. So you extend, leave it after 3 seconds. He didn't do it. you take the best response. You do it around 3 times and take the best response. Okay. So the right side didn't come, maybe because he's got a cannula in the elbow there. So that is what you have to report also. Okay. So you flex, then you extend, leave it for you hold it there for 3 seconds and then you release. And then you look how fast it comes back and how quickly it comes back. Okay. 3 more, just a couple of more. Palmar plantar grasp, I think they will do. I will show popliteal angle because that's important. Now, you would notice by this time that we have undressed the baby. So posture you can see before undressing the baby, and then you can undress the baby. Okay. You look at the posture again once you have undressed the baby. This is popliteal angle. So you hold on either side of the knee, flex it onto or by the side of the hip. And then you use your index finger to, so you can face such difficulties, to extend the leg. So you're looking at the angle between the thigh and the calf. Do it on both sides separately with your head in midline, like that. So this technique, they will always ask you. So just see once more, hold. Wait, I will just replay it. This is a very common question. So you hold on either side of the knee, flex the knee onto the side of the abdomen and use your index finger to extend the leg. All right. And then look at the angle between the thigh and the thigh. And you do the other side. All right. So that is a common question again. Now, traction. Yeah. This is what we use for active tone. Yeah. There you go. So I covered him because he had actually become irritable by then. You console them, you speak to them. He needed some rocking so that he'll be touching the baby to console. So that item you can already score. Sorry, she wouldn't keep quiet if you just talk. You have to actually do some actions to make her keep quiet. Now, this is arm traction. You hold the wrist. You do it one at a time, unlike recoil. Hold the wrist and try to extend. You look at the angle in the elbow when the shoulder goes up. That side is not ideal because the cannula is there, but I still did it. Now we'll see leg traction. You hold the ankle. Do it separately. And go anti-gravity and look at when you will feel resistance when the buttocks is lifting on. There you go. Actually, I see a small asymmetry. The right side was much looser than the left, but probably because she was so agitated. Okay, that's why I told them to stop the video also. Yeah, this is how, what else is there? Visual, I showed you. Auditory, I think last time I showed you. Quickly, one neurobehavior I will show you. This also last time we did. This is my old video. So that's a wrong stimulus to use. I didn't have a ball. And like I said, she didn't seem very interested in that. But she was actually alerting. Can you see her eyes? So the alerting response you will look at when you are giving a stimulus. She is tracking. Okay. Now the bell is not an ideal method. Again, I will tell you what is. So again, she is alerting. But she wouldn't, yeah, can you see? She opens her eyes a bit. The same thing she will do when, there you go. Okay, she's not turning her eyes to that direction or anything, but there is some response in her facial expression, as in she's opening her eyes good. So the auditory response is supposed to be done by using a broadband rattle rather than a bell. A bell is too high frequency and too loud. You're supposed to use a rattle, a grr type of rattle. Like telephone rattle, if you've seen, you can check online what a telephone rattle is. It comes in the DDS kit as well. I think that's enough, ma'am.
Okay.
Yeah.
Great. Thank you so much for such a elaborate session on scoring of CNS scoring for newborn. And students really enjoyed. That's what I can see because of their presence in the group. So let's wind up.